Good morning, ladies and gentlemen. Welcome at the fourth lecture concerning the topic of joints. We are going to continue in the knee joint, just to review the basic information which we have talked about last time. Knee joint is the most complex joint of the human body. It's a compound bicondylar joint. It has got two heads and two fossae. For the femoral tibial joint, the fossa is the superior articular surface of tibia, and the head are femoral condyle. And for the femoral patellar joint, the head is patellar surface of the thigh bone, and the fossa is the articular surface of patella. The articular capsule is attached to the articular surfaces, and there are two exceptions to the margins of the articular surfaces, of course. There are two exceptions: suprapatellar recess above, which we have here and is connected with the suprapatellar bursa usually, and subpopliteal recess, which we find on the lateral side just above the head of fibula. And inside we find many interesting structures, two menisci, medial and lateral, and articular muscle, which is the deepest part of the quadriceps femoris muscle, several synovial bursae around the knee joint. Inside, below the level of patella, we find a fat pad, and at the same level, we find a synovial fold, which then splits to sides as so-called alar folds. So that's the brief overview of the main structures. And now, again, to review the ligaments. Here, the strongest ligament is the patellar ligament, which is a prolonged insertion of the quadriceps muscle tendon. And in between, we find patella. It is strengthened on sides by two retinacula and medial and lateral patellar retinaculum. Then on lateral aspect, we find the tibial collateral and fibular collateral ligament. The tibial is grown together with the medial meniscus. The fibular is in a distance from the lateral one. There can be a burst in between. Then we have ligaments inside, and inside we find the only true intra-articular ligament which is not covered by synovial membrane. That's the transverse genicular ligament, and then two ligaments which are not true intra-articular as they are located outside the synovial cavity, and that's the anterior and posterior cruciate ligament here, or the anterior here and posterior here. The posterior cruciate ligament is strengthened by weak ligaments, and they are called meniscofemoral anterior meniscofemoral and posterior meniscofemoral ligaments. Okay, and now let's talk about the details for the menisci. So, as for the shape of the menisci, we have already talked about the shape. The medial meniscus has got a shape of letter C, so it's oval or semi-oval. The lateral has got a shape of an O, so it's semicircular or circular. And the shape is based on the shape of the articular surface, superior articular surface of tibia. So that's for the shape. Of course, the function of meniscus is to level or equalize the incongruities of the articular surfaces, but unlike the disc, they are movable, so they move during the flexion and extension, and they function as a shock or hit absorbers. Yeah? They are, of course, fixed. They are fixed into the anterior and posterior intercondylar areas by their ends. And they are also fixed by their external margins to the joint capsule. And they are fixed and moved by muscles, the lateral by popliteal muscle, and the medial by semimembranous muscle. And the medial meniscus is fixed to lateral collateral ligament. The lateral one is not fixed to fibular collateral ligament. As for cross section, they have a wedge shape. They are wedge shaped, and it's a fibrocartilaginous structure, and it's supplied by blood vessels only to you can say 1/4 to 1/3 of its external perimeter. And what is their function? Their function, as I said, is to absorb shocks and to move during movements. And all the joint, the whole joint is stabilized by ligaments, by muscles, and also by a structure which is called iliotibial tract, which is a connective tissue, fibrous structure, into which inserts one of the muscles, which is called a tensor of iliotibial tract. And of course, both collateral ligaments are stabilizers of abduction and adduction. As for the intra-articular ligaments, the only true intrasynovial ligament is the transverse genicular ligament. It is not covered by the synovial membrane, it is really inside. The other two much stronger ligaments are cruciate ligaments, and they are positioned dorsally to synovial membrane. So they are intra-articular but extrasynovial. So you can approach them either dorsally, extrasynovially, but usually they are approached through the articular cavity during arthroscopy of the knee joint. So the anterior cruciate ligament originates on the lateral femoral condyle on its medial surface, that means inside intercondylar fossa, and attaches into the anterior intercondylar area. And the function is to stabilize the ventral movements of tibia and to prevent too extensive internal rotation of the leg and to prevent hyperextension. On the contrary, posterior cruciate ligament originates from the medial condyle of the thigh bone. The posterior cruciate ligament originates from the medial condyle from its lateral surface and inserts into posterior intercondylar area. Yeah? And the function is, again, a stabilization of the movement, but in this time of the dorsal movement of tibia. So these two ligaments are important that they are stretched during flexion of the knee joint, and during internal rotation, they wind around, they wrap around each other, and they stabilize the knee, and this position is then called locked knee. Yeah. So here we can see again the anterior and behind that located posterior cruciate ligaments. And the last ligaments we have not talked about are located dorsally. They are part of the articular capsule. And we can see here the oblique popliteal ligament, which is one of the insertional part of semimembranous muscle, one of the three attachments of the semimembranous muscle. And the other one is so-called arcuate ligament. It's thinner one, and it has got two limbs, and it is attached to the head of fibula. So these are the last ligaments of the knee joint. This figure shows us the fat pad of Hoffa, which is located below the of patella. That's why it's called infrapatellar fat pad. Then other special structures of the knee joint are synovial bursa. The figure and the list of the synovial bursa shows you where they are located and where they absorb the friction forces which appear during movements. We have already talked about the subpatellar bursa, which extends the suprapatellar bursa, which extends the suprapatellar recess. Then we have bursa located in front of patella, and they are two, subcutaneous and subfascial, and they can be inflamed during prolonged kneeling. Then we have two infrapatellar bursae, subcutaneous and the deep one. And then out of the other ones, we can stress this gastrocnemius semimembranous bursa, which is located between the semimembranous muscle and the medial head of gastrocnemius muscle. And this bursa can be pathologically enlarged and palpable dorsally in the popliteal fossa, and then it's called the Baker's cyst. Yeah? But all of the bursae can get inflamed, enlarged, and then they are either palpable or they can be examined by ultrasound. Yeah, on this figure we can see the suprapatellar bursa, the location of the prepatellar bursa, the subcutaneous and subfacial, the infrapatellar, subcutaneous and deep bursa. And in this cross section we can again see the infrapatellar fat pad located here, and the suprapatellar bursa, which is a continuation of the suprapatellar recess. So the movements of the joint, as it is a compound bicondylar joint, it is a biaxial joint. So what we are able to perform is the flexion extension. The anatomical basic position is the full extension. So from the basic position, we are able to perform only flexion, but to 150 degrees. And then the movement back is extension. In case of full flexion or extension, the cruciate ligaments are wrapped around each other. That means the knee is locked. And in locked knee, we are not able to perform any rotation. To perform rotation, we have to relax the cruciate ligaments. And so this can be in between 0 and 150 degrees. Yeah. So only when the knee is a bit flexed, we are able to perform rotations. The internal rotation is, the extent is smaller, and we have 4 muscles to perform that. External rotation is larger, up to 40 degrees, and it is performed by biceps femoris muscle. Okay, during flexion, the leg bones and the menisci and thigh bone performs 3 different movements. Yeah, so we are going to talk a bit closer about that. So in full extension, in basic anatomical position, we are in a position of the locked knee. To unlock the knee, we have to relax the cruciate ligaments, mainly the anterior one. And this is reached by rotation of tibia. Yeah? Tibia rotates internally 5 degrees. In 5 first degrees of flexion, the tibia a bit rotates medially. And then starts the real flexion by first rolling and then sliding of femur on the tibial surface. And at the end, the menisci change their shape, which is well visible in this figure shown before. Yeah. When you see this rolling and sliding movement, then the sliding movements a bit deformates and moves the menisci. Yeah? As you can see here, moves the menisci dorsally. So just to repeat, we start with the initial rotation, which unlocks the knee and relaxes the anterior cruciate ligament. then the femur rolls and slides on tibia, and at the end it a bit deformates menisci. And it is visible also here. The locked knee in extension is visible here. You can see that the ligaments are stretched. Then after unlocking the knee, that means the initial medial rotation of tibia, you can see that the anterior cruciate ligament and also here the collateral ligament, they are relaxed. So we start to roll and then we slide. And at the end of the slide, the anterior cruciate ligament is again stretched. So the knee is again locked. So we are not able to perform rotations in full extension and in full flexion. Yeah? And also you can see here how the meniscus is moved dorsally and a bit deformed. X-ray of the knee joint in anteroposterior and lateral position. You can see nicely here the shape of patella, which is not visible in anteroposterior projection. And we see, of course, here the articular cavity. And you can see that fibula is not part of the knee joint totally. Again, the projection of patella, nicely visible here, and here the intercondylar eminence of tibia, also visible. And this X-ray shows you on one side an reduced articular cavity width. That means here is an erosion of articular cartilage. And this erosion of articular cartilage is a sign of arthrosis. And on the other side, we see a total replacement of the head and the fossa of the knee joint. Okay, some clinical notes before we close the topic of the knee joint. You know that the suprapatellar recess is a spot of the knee joint puncture, and that it often communicates with suprapatellar bursa. And the puncture allows us to get a fluid. And when the fluid is clear, the fluid can contain, of course, cells during inflammation, white blood cells, or bacteria. The clear fluid we can get also in arthrosis and overload, but it can be colored to red or brown in case of presence of blood. For example, in ruptures of ligamental capsule, then we call it hemarthros, blood in the joint. And in case we have a fracture of the bone, which is also visible inside the joint cavity, so it's an intra-articular fracture, and then the fat can get into, and we can see the blood with fatty eyes on it. So as for the synovial bursa, we have already talked about the Baker's cyst. So I again remind you of the complicated term Gastrocnemius semimembranos bursa between semimembranous muscle and medial head of the gastrocnemius muscle, and it's palpable dorsal in popliteal fossa, the Baker's cyst. And here, just to inform you about some clinical notes, anterior cruciate ligament and tibial collateral ligament are the more often injured structures. And as for the anterior cruciate ligament, it comes in violent abduction and external rotation of the leg, mainly in football players, for example. The tibial collateral ligament is injured mainly on locked extended knee from external side, so in some fighting sports. And the medial meniscus, which is grown together with the tibial collateral ligament, is much more often injured So if we combine this, and it can happen to you mainly during skiing when the leg and ankle and foot is fixed in the skiing boots, then the combined injury of the tibial collateral ligament, medial meniscus, and anterior cruciate ligament happens, and it's called an unhappy triad. Yeah. So then, after such an injury, the knee joint should be examined. So the collateral ligaments serve for lateral stability. So you try abduction and adduction, which should not be allowed in this joint normally. The cruciate ligaments are responsible for anterior and posterior stability. So you perform something which is called a drawer test. Yeah? So we can look at some figures. Here we can see what happens during the triad, unhappy triad. That's a rupture of the tibial collateral ligament and the medial meniscus and the anterior cruciate ligament here. And finally, you can see the whole triad here. Yeah. The tibial collateral ligament is sometimes in clinics called medial collateral ligament, but in anatomy we do not use it, as medial collateral ligament is located here in the ankle. And we'll come to this in some minutes. So how to examine? Here you can see the drawers test, that you draw this flexed lower limb ventrally or dorsally, yeah? And then you test anterior posterior cruciate ligaments, for example. For the collateral ligaments and for menisci function, we can test this spiral contra rotation of leg and thigh, and this compression on the medial side of crossed lower limbs. Well, this is just for information, and of course puncture of the knee joint we have talked about. The knee can be also luxated, and you can see the luxation can happen ventrally, dorsally, or laterally. For the dorsal luxation, what is the most dangerous situation is for the vessels and the nerves, yeah? And we will talk about these vessels and nerves then later. So the knee joint can be also luxated. And here you can see some figures from the operation. For example, the lateral, the anterior cruciate ligament can be replaced by, for example, a patellar retinaculum transfer, or we can take a tendon, insertional tendon of gracilis or a sembitendinous muscle and put it in and fix it. And then you can see here the screws which fixates the replaced anterior cruciate ligament. And it is performed, as you can see, the instruments here, it is performed in an arthroscopic manner. Okay, that's all for the knee joint. And now we continue more distally. Here we have one very easy joint. It's a simple plane, that means triaxial and not much movable. That means amphiarthrotic joint. We call it Tibiofibular Joint. And you remember, Tibiofibular Joint is proximally. So it is between us, it's a plane joint. There is no fossa, no head. And it's between the head of fibula. So we have articular surface of the head of fibula, and we have a fibular surface on the side of shaft of tibia. Yeah, so we have here a fibular articular surface of tibia. It is supported by two ligaments, anterior and posterior ligament of head of fibula. And that's all the information we can get. So let's look at the figure, and we look from above. So you can see the head of fibula, two ligaments, anterior and posterior, and the articular surfaces between the head of fibula and between the lateral part of the shaft just below the lateral condyle of tibia. Yeah? And it allows only small movements in all directions. So we have to talk about this, which is the Tibiofibular joint. In Latin, it is called Articulatio capitis fibulae, so articulation of the fibular head, but in English, Tibiofibular joint. But Tibiofibular joint can evoke an imagination of this connection. But this connection is tibiofibular syndesmosis. And the tibiofibular syndesmosis is composed of membrane. So this is a leg interosseous membrane, membrana interossea cruris. Yeah. Don't forget that crus, cruris, neutrum is a word meaning a leg, but it also can mean a limb. Leg, but it also can be, for example, a limb in the heart of the heart conducting system. But in this case, it is a Latin name for leg. And then we have another part, and that's a thickened fibrous joint, which we find here. And that's the real syndesmosis in clinics. And so when I come back to this membrane, it's very thin, firm membrane between the bones, yeah, very similar to interosseous membrane of the forearm. But here at the end, unlike the wrist, here above the ankle, we find syndesmosis, which is a fibrous structure, quite thick one. Yeah, in anatomy, it is not a special term. It's just the distal part of the tibiofibular syndesmosis. But in clinics, if you talk about the tibiofibular syndesmosis, you just mean this part, which is strengthened by anterior and posterior tibiofibular ligament. And on one side, it is attached to a fibular notch on tibia. On the other side, it is attached on an innominate tuberosity on fibula, which you find above the articular surface. Yeah? And this is very firm, but still a bit movable fibrous joint. Just above it, and here below the tibiofibular joint, so below the joint and above the syndesmosis, we can find two openings. And these openings serve for vessels to pass through. The superior one serves for anterior tibial vessels. The inferior one serves for a small branch of the fibular artery, which is called the perforating branch of fibular artery. So that's all for the tibiofibular syndesmosis, anatomically. And clinically, what can happen is a fracture of the malleolus. When the fracture of the malleolus is below the level of syndesmosis, in clinics it is designed as a fracture Weber A type. When it goes through the syndesmosis, as you can see here, it is Weber B type. When it goes above, it is Weber C type. If it goes through, or if the syndesmosis is ruptured, then you need to put a screw here in. But the screw is there located only, it's there only for 1 or 2 weeks, and then you have to take it out. Otherwise, the syndesmosis would change into synostosis, and you will lose the possibility to move the joint a bit, yeah? In jumping, for example, it's necessary. Then these two spaces can move a bit against each other. Yeah, so this we need, and that's why you should remember that here exists a syndesmosis, and if you apply a screw here, the screw can be here only for a limited time. Okay, here you can see the view into the syndesmosis from below, and there we find a very small recess tibiofibular recess of the Inca joint. So this is what we see is the Inca joint. And here is a small recess, tibiofibular recess, which forms the floor of the tibiofibular syndesmosis, which is then strengthened by two ligaments, anterior and posterior tibiofibular ligament. So that's all for the syndesmosis, which is clinically very important. This X-ray shows you the fracture of here. You can see the fracture of fibula, which is above the syndesmosis, so it's Weber C, and it's usually accompanied by a fracture of medial malleolus as well, which you can see here. And now we can continue to the foot. The joint connecting leg and foot is called Inca joint, or in Latin talocrural, as it's located between talus, the most superior bone of tarsus, of the foot, and crus, which is the leg. And it's a compound joint, it's trochlear joint. That means it will be only monoaxial joint. And when it's trochlear and monoaxial, there should be, of course, typical collateral ligament. So we have medial collateral ligament and lateral collateral ligament. It is not so easy. The lateral collateral ligament consists of 3 separate ligaments. The medial one consists of 4 unseparate parts. Yeah? And it is sometimes called deltoid ligament in clinics, as it looks as the uppercase Greek letter delta. I will show you the ligaments in a minute. As for articular capsule, we have talked about the tibiofibular recess, which is a shallow recess proximally heading towards the tibiofibular syndesmosis. Of course, head and fossa, it's a trochlear joint, so the head is trochlear, but it's not only the superior surface, but also on sides we find the medial and lateral articular surfaces. And the fossa is the inferior articular surface of tibia, and of course, for the malleolar surfaces of talus, there should be malleolar surfaces there should be articular surfaces on the malleoli themselves, so on medial and on lateral malleolus as well. So then the head and the fossa looks really like two letter U inverted shaped of letter U, which goes above, and you can see that the articular surface is composed of 3 different plane surfaces. When it's monoaxial joint, we have only one movement, and that's plantar dorsal flexion in the extent of 30 to 50 degrees. Yeah? The movement is not so easy, as the 2 distal part of bones of tibia and fibula, they form a cleft in between, tibiofibular cleft. And the trochlea of talus, if you look from above, yeah, so this is ventrally, and this is dorsally. So the trochlea is wider ventrally than dorsally. Yeah, wider ventrally than dorsally. So during plantar and dorsal flexion, so during the movement ventrally and dorsally, we narrow and enlarge the tibiofibular cleft, yeah, due to the wider talus. And this widening and narrowing is allowed by the existence of tibiofibular syndesmosis, which we have talked just a minute ago. So in case there is no syndesmosis, it is not possible to allow this widening and narrowing of the tibiofibular cleft, and the plantar and dorsal flexion is not possible to be performed, mainly the dorsal flexion, as you can see that ventrally it is enlarged, yeah? And the dorsal flexion you perform, of course, ventrally on the foot. If this is the foot and leg with the ankle, then dorsal flexion is this movement. So the movement which is performed on the ventral aspect of the bone. to see some figures. Here we have the collateral ligaments, yeah? And this is the delta-shaped ligament consisting of 4 parts. And you can see that these 4 parts are called according to the bones to which the ligament extends. So it is composed of tibio-calcanear part, going to calcaneus here, tibio-navicular part, going to navicular bone here, and 2 tibio-talar parts, anterior and posterior, which we have here, the anterior, and here, the posterior. So on medial aspect is 1 ligament composed of bends. On the lateral side, on the contrary, we have 3 independent ligaments. Yeah? Again, they are called according to the bones. So we have calcaneofibular and 2 talofibular, anterior and posterior. So you can see the calcaneofibular. You can see here the anterior tibiofibular and here the posterior tibiofibular, which is inserted into the fossa of lateral malleolus. So 3 independent ligaments laterally. So the medial ligament is, of course, thicker. As for the movements, we have talked about the plantar and dorsal flexion, which is 20 to 30 degrees dorsally and 50 degrees plantary in a plantar direction. And what is very important on X-ray, you can see the cleft. And if you see the cleft, it is reaching more distally on the lateral side as fibula is longer. So this is lateral malleolus, and lateral malleolus reaches more distally, is longer. So the cleft is also longer on the lateral side, and the articular surface of talus, the lateral articular malleolar surface, is also larger. Here is the recess, the tibiofibular recess, and here we find the tibiofibular syndesmosis, and here then we find the leg interosseous membrane. Yeah? From the lateral projection, we can see here the articular cleft or the articular cavity, and you can also see here how deep or how distally reaches the lateral malleolus and how short or more proximally located is the medial malleolus. So this is very important, that this fork is not symmetrical and it's shorter on the medial side. Huh? Okay, that's for the ankle joint. And some clinical notes about this joint is that during every movement in this joint, as the talus is wider ventrally and narrow more dorsally, the fork of these 2 bones is still moving, and this movement is allowed by rotation. And this is a rotation of fibula, as tibia is the main weight-bearing structure, and the fibula can easily rotate. That's why fibula a bit rotates during these movements, and it rotates internally during plantar flexion and externally during dorsal flexion. Yeah? The ligaments are very often injured during sports, and as I said, the medial one is stronger. Lateral is not so strong, and the injury in supination of the foot, we are going to talk about the supination of the foot in a minute, is more common. That's why the lateral ligament is more commonly injured one. Okay, now to talk about the movements of the foot as a whole, we need to go through some other joints which we can find in foot. So then the other joint is Talocalcanel joint. which is below talus. That's why it's more commonly called subtalar joint. Subtalar joint is the only pure cylindrical joint in the human body. It is not a trochlear. The surface is a real cylinder. So it's again a monoaxial joint like the ankle joint. The head is the posterior surface of calcaneus for talus, so posterior talar articular surface of calcaneus. Yeah, and it looks like that. And then, of course, the surface on talus for calcaneus. That means posterior calcaneal articular surface of talus is similar. So this is talus calcaneus. Yeah, you can see that it's a real cylinder. Even I cannot draw so well. And it is supported by ligaments, and you find the ligaments from medial side, lateral side, dorsal side, not from a ventral side, not from anterior aspect, as there are other bones, but even in between. And you know that talus and calcaneus, they've got a groove, and when these two grooves meet, we call it a tarsal sinus, sinus tarsi, and inside that we find the interosseous calcaneal ligament. And as for the movements are common for the whole foot, and we call them inversion and eversion. I come to this in some minutes. So let's look how the joint looks like. We can come back here. We can nicely see the joint here. Posterior talar articular surface of calcaneus, posterior calcanel articular surface of talus. So this is the joint, yeah? And this is sinus tarsi, where we can find interosseous calcaneal ligaments. This figure shows us the posterior talar articular surface of calcaneus. So this is the extent of the subtalar joint. What you can see here, the middle, this was the posterior, the middle and the anterior talar articular surface of calcaneus are part of another joint, together with here, the navicular bone. Yeah, and its posterior surface, the concave surface. These three articular surfaces form a joint together, and a complex joint. And this is the articular capsule. And this joint here contains a fibrocartilage. So you can see there are 4 structures for the joint. So this joint has got its capsule and this joint has got its capsule. That's why we distinguish 2 different joints. The posterior joint, I can write it here, which is called articulation, which is subtalar joint, articulatio subtalaris, or tallocalcanea. And the other joint, which is here, and this joint we call articulatio tallocalcaneonaviculare, so tallocalcaneonavicular joint. Yeah? And it's based on the articular capsule arrangement. Here we can nicely see the subtalar joint with sinus tarsi and the interosseous tallocalcaneal ligament. And then we can, so this is the posterior surface, here will be the middle surface and the anterior surface, and then the navicular bone. And talus has got the posterior surface here, and then the middle and the anterior surface here. And this is the caput. So the head of talus, caput tali, which is forming the head in this tallocalcaneonavicular joint. Yeah? So here you can see 2 joints with separate articular capsules. So the tallocalcaneonavicular joint, as I said, is a compound joint, ball and socket, as the head is head is the head of talus capitali, and I'm sorry, here's a mistake. Anterior. Yeah, here should be anterior. And middle calcanel articular surface, as the posterior is the part of the subtalar joint. And the fossa, then, of course, here is again a mistake and should be anterior. I'm sorry for this mistake. Anterior and middle talar articular surface of calcaneus and articular surface of navicular bone. Yeah, the posterior concave surface. How this ligament, how this joint is supported and fixed. We have talonavicular ligament between the caput tali and the articular surface of the navicular bone. We have the calcaneonavicular plantar ligament, and we have the calcaneonavicular dorsal ligament, yeah, between calcaneus and navicular bone. And I said that the fossa is enlarged by a fibrocartilage, and the name of the fibrocartilage is navicular fibrocartilage. As for the joints, again, the movements are common for the whole foot, called inversion and eversion. And another joint is next to it, and it's called Calcanel Cuboid. Yeah? It's a very easy joint. It's a plain joint. The articular surface is a bit waved, so sometimes it's called saddle-shaped, but it's an amphiarthrosis, so there are no special movements as in the saddle joint, which we find in the hand. So this is just a saddle-shaped amphiarthrosis. So the movements are limited, small in all three directions. Yeah, so there is no head and fossa, as it's a plain joint. So we have cuboid articular surface of calcaneus and calcanel articular surface of os cuboidum. And then again, there are some ligaments, calcanel cuboid plantar ligament and calcanel cuboid dorsal ligament. Movements limited, and they are, of course, part of the movements of the whole foot, so inversion and eversion. Yeah? So this is a very anatomically very easy joint, which we can see here, calcanel cuboid joint, and you can see here the dorsal calcanel cuboid ligament. The plantar would be from below. Yeah? And you can see it's a plain joint with a not nicely shaped articular surface, so it's amphiarthrosis, similar to sacroiliac joint. Yeah? It's also a plain joint with uneven surfaces. Well, this is the other side. So from this side, we can see the talo-calcaneonavicular joint, which is located here. And you can see the ligaments like dorsal talonavicular ligament and yeah. Now we have here a functional joint. Functional joint from two points of view. One is the clinical, that you can distort this joint. And second is surgical, that this joint was used for amputation, to cut the distal part of the foot. This articular cleft was used for that. Now we prefer to cut the bones, as we are able to then smooth the sharp edges of the cut bone. And these two clefts, which you can see there, that means calcanel cuboid joint, calcanel cuboid, located laterally, and talonavicular part, as you can see, the head of talus, capitally here, and navicular bone here. So the talonavicular part of Talocalcanonavicular joint. So these together form such a S-shaped joint. You can say it's similar to a medial carpal joint of hand. And this joint is called tarsal transverse joint of Chopard. Yeah, that was the guy who performed amputation in this joint. So please remember this functional joint in which the foot can be injured. Transverse tarsal joint of Chopard, composed of lateral Calcanel Cuboid component and medial talonavicular component, which is part of the talocalcanonavicular joint. Yeah? Okay. Then we can proceed further to distal tarsal joints. All these joints are amphiarthroses. It's similar to intercarpal joints of the hand. These, which could be called intertarsal joints, but they are not. They are called according to the bones. So we have the cuneonavicular joint here. We have the intercuneiform joints, which are here. And we have Calcanel Cuboid joint between the lateral cuneiform and cuboid bone. All these are strengthened by ligaments located plantarly, dorsally, and in between the bones. All of them are amphiarthrosis. So there is no special injury or disease of this small joint. You just should realize that the joints exist here and are quite stiff. Okay, now to conclude the ligaments of this distal area, we have the ligaments which are dorsal, which are plantar, and which are interosseous. And they are located in between the bones, so you can find the names here, but the names are just based on the bones which they interconnect. And then we have one ligament which is called long plantar ligament. And the long plantar ligament you can see here, and it originates on the inferior aspect of calcaneus and terminates on heads of metatarsals. Yeah. Basis of metatarsals. I'm sorry, basis of metatarsals, as the heads are here, basis of metatarsals. And this is a quite long and very thick ligament, which also contributes to the longitudinal foot arch. So this is for the ligaments. And when we continue in the joints, then we have these tarsometatarsal joints. Yeah? Unlike the carpometacarpal joint, this joint has a cleft which is not nicely shaped. But what is important is this, this position. You can see that the second metatarsal bone and its base is located more proximally than the other ones. So this serves here as a peg, yeah? And this peg helps us to keep the arch of foot firm and stiff. And all these clefts of these tarsometatarsal and intermetatarsal joints together, it forms a special joint which is called the Lisfranc joint. I will come to that in a minute. Yeah? So these are again amphiarthrosis, stiff, usually plain joints, which are supported by dorsal, plantar, and interosseous ligaments, tarsometatarsal. Yeah? And they form this special Lisfranc joint. So the Lisfranc joint is a combination of tarsometatarsal and intermetatarsal joint. It again can be contused or injured during the movements, and it also served as a cleft for exarticulation in amputation. Yeah. Okay. And don't forget that the base here serves as a peg or as a hinge against the cuneiform bones. Of course, then we have the metatarsophalangeal joints here. metatarsophalangeal, and then the interphalangeal joints. But they are similar to these joints in hand. The only difference is that these metatarsophalangeal joints are not elliptic, but they are plane. Yeah? Ellipsoid, they are not ellipsoid. They do not allow such movements as in the hand. They are just plane. But they contain fiber cartilages and they have collateral and plantar ligaments. And the heads of metatarsal bone here are interconnected by one ligament, and the ligament is called deep transverse metatarsal ligament. It's similar to deep transverse metacarpal ligament. So there is nothing special about these joints. And if you look at the X-ray, on the X-ray you can see that the cleft of the Lisfranc joint is not a nice cleft. The Chopard joint is something like S-shaped, which is here, or here. But the Lisfranc one is not like that. You can see these two lines, or here you can see these two lines, and it's due to the proximal shift of the second metatarsal, which serves as a peg or a hinge for the joint. Yeah, so the cleft is not so nicely visible. Another difference between hand and foot is that the foot has got an arch, and then it continues here. You can see the arch, which is between the heel and the heads of metatarsals. But then you can see these angles. Yeah? These angles between the proximal, middle, and distal phalanges. In hand, it is like that. Yeah? In foot, it is like that. So we have the proximal, middle, and distal phalanx. Yeah, in hand, it is either extended or flexed, but this is basic position in foot, which allows us to fix well the foot on the surface during gait. Yeah. Okay, we have talked about all the joints and ligaments, and now the movements. The movements are usually a combination. So of course, plantar and dorsal flexion. Yeah, I can use my hand as my foot. So imagine that my forearm is the leg and my hand is a foot. Yeah? So what I can perform is the dorsal flexion and plantar flexion. Yeah, that's very easy. Then I can perform abduction and adduction. Yeah? The extent is quite small, only 5 to 10 degrees. And then I can perform something like a pronation and supination. It is not a real pronation and supination, as I do not rotate one bone around the other. Yeah? Radius around ulna. Fibula and tibia do not move in this movement. It is just that I flip a bit the whole foot on one and the other side. Yeah, pronation, supination. Yeah, not a real pronation and supination, but the terms are used. But usually you move the hand, the foot in plantar flexion, dorsal flexion, plantar flexion, and then you move it as a whole. Yeah, so you move it like this way or that way. This way is called eversion, as you can see also on the figure. Eversion means that the lateral margin goes up. Inversion means that the medial margin goes up. Yeah? And technically said, inversion is a combination of plantar flexion, so plantar flexion, adduction, and supination. And in this movement, the medial margin goes up. Yeah? Plantar flexion, adduction, and supination. and medial margin goes up. Eversion means dorsal flexion, abduction, and pronation. Yeah? Dorsal flexion, abduction, pronation, and the lateral margin goes up. So here is a lateral margin, here is a medial margin. Okay? So these are the movements as a whole, inversion and eversion. And you can try it yourself that inversion is twice larger in extent than eversion. Yeah? Please try it yourself so you understand all these movements. Okay, to conclude the foot, we have to talk about the arch. We have here two arches. Transverse arch, which is just at the level of the heads of metatarsal bones, yeah. And longitudinal arch, which is between the heads of metatarsal bones and the posterior part of calcaneus. And this is composed of two lines. The medial line goes through talus and navicular bone and cuneiform bone and the first metatarsal. Then the lateral one goes through Calcanel Cuboid bone and here the tuberosity of the fifth metatarsal and the fifth metatarsal. Yeah, so this is the lateral line and the medial line. But this would not hold without supporting structures. So which are the supporting structures? The supporting structures are all the ligaments between the adjacent bones, yeah? Talonavicular, Calcanel Cuboid, and so on both sides, dorsal and plantar, and interossals as well. Long ligaments, and we have one long ligament, a long plantar ligament, which is stretched between the calcaneus and the bases of metatarsal bones. Then we have short muscles of foot. We will talk about them, for example, flexor digitorum brevis muscle. Then we have long muscles of foot. Long muscles of foot means muscles which are the muscles of the leg, tibialis anterior, posterior, flexor digitorum longus, flexor pollicis longus, and flexor hallucis longus. And these muscles feature only tendons in planta, yeah? But these tendons also together with the muscle bellies, they support the arch. And then on the surface, we find plantar aponeurosis. What is plantar aponeurosis? If this is a foot, and also in hand, we have palmar aponeurosis. So plantar aponeurosis is superficially located, thick, flat tendon lying in this area. Yeah? And tibialis anterior forms such a tendinous stirrup. So if you look at the figure, we can see the structures here, yeah, the short ligaments here, the long ligaments, long plantar ligament here. The short muscles are not shown. Plantar aponeurosis is here, and you can see these tendons of the long muscles, yeah. And you can see the stirrup, which is formed here between the tibialis anterior and fibularis longus muscles. Yeah, it's it really reflects a stirrup used when riding a horse. For a transverse arch, what is for us important are, of course, the ligaments which run transversely, so the short ligaments in foot, and the stirrup formed by tibialis anterior and fibularis longus muscle. So the fourth arch is, of course, important for rebouncing from the floor we are walking on, and you can see that we touch the floor at the heel and then at the heads of metatarsal bones, mainly the first and second one. So the foot arch helps us to carry the body weight, mainly by dorsal or posterior part of calcaneus, which is called the calcaneal tuberosity, and then the head of first metatarsal, second metatarsal, and then so on. We need a great toe for bounce of foot from the floor when walking, jumping, running. And if we have problems with the arch, it does not allow us an easy and unpainful walking. And we have a different kind of these problems. We can have a too high arch, then it's called excavated foot, so it's called pes cavus, as you can see here. On the other side, when it's too low arch, so when the arch collapsed, it's called a plain foot, pes planus, and it can be plain either in the longitudinal one or it can be plain in the transverse arch, so then it's called transversal plane, pes transversal planus. Yeah, these are just the basic problems with the arch. The last clinical information here comes for two osteophytic structures which can appear, and they are called calcar. And they can appear either here in the insertional tendon of the triceps surae, so in the Achilles or calcaneal tendon, then it's called calcar avis of Haglund. Or it can appear here in this area, then it's called the heel spur or calcar, and it's usually in the insertion of the short muscles of the foot or plantar aponeurosis. Yeah, the plantar aponeurosis is the more inferior position. It usually appears when during an overweight or when wearing an inappropriate shoes. Okay, that's all for the joints of the lower limb. And to conclude the bones and joints of the limb, we just should shortly talk about the development of the limbs. As we know, the bones can ossify in two ways. One is called membranous or intramembranos ossification. It happens in connective fibrous tissue, so sometimes it's called a desmogenic ossification, and it's present mainly in flat bones of the skull, so the cranial bones like parietal, frontal, occipital, temporal, and for example in clavicle as well. And the other kind is the formation from cartilage, so it's called cartilaginous or chondral or chondrogenic development, and that happens mainly in growth plates, for example. Yeah, so here you can see figures from proximal growth plates of a newborn humerus. So the growth in the epiphyseal plate has got several stages, and you can see here the full cartilage, and here you can see the full bone with the cavity. It is not a real full bone, and as it is the primary bone, yeah, primary fibrillar bone, which forms just the lamellae, but it then will remodulate into the secondary one. Yeah, and in between we have the cartilage which is ossifying, so we can see proliferation in the second zone, and then we can see the hypertrophy and final degradation of the cartilage by chondroclasts. Yeah, and the calcification will then start here. So these are the histological layers of the ossification, which we can find in the growth plates in future metaphysis. And here we can see such an example of a clinical case, as we have here a boy, and the boy suffered from a fracture in the proximal humeral growth plate, and we know that this proximal humeral growth plate is responsible for 80% of the length growth. So such a fracture, which happens here in the growth plate, and you can see that the epiphysis was displaced medially and proximally. It can cause either disruption of the movement of the growth, or the growth can be accelerated. So then there can be problems in the final length of the upper limb. Okay, you can see that the development of the limb is quite similar in a different species, as already Charles Darwin was thinking about that. You can find the differences between a nice hand of a human, which is able to perform different tasks, and for example a bat wing, which is, or a bird wing, which is specialized only for one movement. So there should be something behind that, and it was already published in The Origin of Species, which is more than 150 years old. Now we get a bit closer to that as we understand the genes and the development of all the structures here. As you can see in chicks, that means in birds, the number is smaller than the number in mammalia, which is planned as a 5-1. And we can see that the limbs are already present as buds just at the day 2. We can nicely see them. This is a chick embryo here, and you can see the somites and the new relation which is happening here. And then later in the chicken embryo, which is nicely formed here, you can see already the formed buds. So here are the basis for upper and lower limb in the day 5. There are many genes which are responsible for that, but all of them belongs to the Hox genes family, and they are responsible for a different kind of anterior-posterior growth and the proximo-distal growth, and they are responsible also for the identity and number of the digits, which are 5 in mammalia. In this nice red embryo figure, you can see these black areas, which are areas of apoptosis, which happens here, and then finally it disappears and 5 digits are separate. For example, in duck, where there are not 5 digits, just 3 we can find in between the membranes, as the apoptosis is not planned here. Now, what is the message of this information about the limb development is that we have congenital limb defects, which form 10% of all congenital defects, which is quite a large number. And as you can see from the incidence in Czech Republic, there are about 350 cases of either extended number of fingers, so polydactyly, as the word dactylos means. Dactylos means a finger, or syndactyly, that means that some of the fingers are grown together, so the number is reduced, or there can be a partial or complete absence of the limb itself. And the causes are genetic, environmental, but mainly they are unknown. And as I said, the pentadactyly is the classical digit formula. And just to show you some of these defects, you can see here what can happen to the digits. We can have a polydactyly, which is visible here. There's just 1 digit more. Okay, thank you very much for listening and following this lecture. If you have any questions, you can ask me using my email, and I can share the email here with you, which is david.kachlík@levmotol.cunizz. So you can ask me for anything from joints or other topics by email, or you can ask for a consultation via Zoom if necessary. Again, thank you very much for paying attention, and I wish you have a nice day and successful further study.